Good morning, everyone. My name is Chinua Amamba, and it is my pleasure to welcome all of you to today's events from ODP's Prevention in Focus webinar series. I will be serving as the host and moderator for today's session. First launched in 2021, Prevention in Focus webinar series was intentionally conceived for the purpose of providing a space to hear directly from prevention research experts and thought leaders whose work is driving impactful advances in the spaces of prevention research and public health. Today, we are thrilled to have Dr. Karie Stewart from the University of Illinois Hospital and Health Services Department of Obstetrics and Gynecology in Chicago deliver her presentation on addressing maternal mortality, unveiling racial disparities, and charting a path to change. The next slide, please. Okay. And so, next slide, please. Before we move on to hearing from Dr. Pamela Sutton, who will be providing the opening remarks and introducing our speaker for today, I would like to go over some of the logistics for today's session. So as attendees joined the Zoom today, audio lines were muted. These lines will stay muted throughout the session. Please note that this webinar will be recorded. An archived recording will be posted to ODP's Prevention in Focus website and made available on ODP's YouTube channel in the upcoming weeks. Next slide, please. There will also be a question and answer session at the end of the presentation. Please feel free to submit any questions you have to the chat pod and direct them to host and panelists. At any point in time, you may use the chat pod for general commentary, questions for the speaker, or to request technical assistance. We have an amazing team of ODP staff. One more slide. We have an amazing team of ODP staff who are closely monitoring the chat and working hard to ensure appropriate engagement with our speaker and our staff. And so today, at this time, I'd like to introduce Dr. Pamela Stratton, who will be giving a brief summary of the Pathways to Prevention workshop on postpartum health, and then introducing our speaker for today's webinar. Dr. Pamela Stratton serves as the obstetrician gynecologist physician lead at the Office of Research on Women's Health here at NIH, working closely with the ORWH director, Dr. Janine Clayton. After a 30-year career in the United States Public Health Service, where she conducted clinical research across broad topics in obstetrics and gynecology, from preventing mother-to-child transmission of HIV to developing novel treatments for pain from endometriosis to studying the gynecological and reproductive health in women with complex and rare disease, she joined the Office of Research of Women's Health. She fosters NIH-wide collaborations on maternal health and various women's health research topics. She is ORWH's co-lead on the Postpartum Pathways to Prevention project that culminated in a 3-day workshop called Identifying Risk and Interventions to Optimize Postpartum Maternal Health. So I welcome Dr. Pamela Stratton today.
Thank you, Chino. I'm delighted to be here and have this opportunity to technical difficulty, to present our speaker. But first, I'd like to talk to you about the Pathways to Prevention program that we're in the midst of. As you can see from this slide, we have had this project that is identifying risks and interventions to optimize postpartum health. Next slide, please. The reason we focused on the postpartum period is because more than half of the maternal mortalities in the United States occur during this period. Next slide, please. The Pathways to Prevention program is anchored by a systematic evidence review. The systematic evidence review that we used for this Pathways to Prevention was to think about, on entering prenatal care, what risks might be present that would predict ill health postpartum, and around delivery, what risks might be present that could predict ill health postpartum, and to what extent do these risks vary by race and ethnicity. Next slide, please. The workshop that we had at the end of November presented an NIH portfolio analysis, the systematic evidence report, some presentations, and had audience participation. All of those together are going to the independent panel which is going to be publishing a report that identifies the research gaps and provides recommendations for advancing the field. Next slide, please. We also focused on the structural disparities present in our healthcare system. With, as you can see, we had several talks about how to improve equity that are harmonized with our speaker today. Next slide, please. The key to fixing the structural disparity will be elevating the patient voice and providing patient-centered care, something we discussed at a roundtable on day 2. Next slide, please. Our main takeaways are that the stress test of pregnancy continues postpartum, and we need to bridge the chasm between obstetric care and postpartum care by taking a life course perspective. We can only do this by listening to the patients and their families. The workshop recordings and other resources are available on the ODP website. We expect the independent panel report to be published alongside the systematic evidence review later this year. Next slide, please. This fall, we are going to be having a federal partners meeting with our tremendous allies across HHS. They will be writing an action plan or a report that will be translated into an action plan. And that will be fed into our ongoing activities called the Improve Initiative, which is implementing a maternal health and pregnancy outcomes vision for everyone that is currently coordinated by the NIH Coordinating Committee for Maternal Morbidity and Mortality, otherwise known as the CCM3. You can access these vital resources by going both to the Improve Initiative and the Coordinating Committee later. It will give you insights into what funding opportunities are available. And now I would like to introduce Ms. Stewart. Karie Stewart is a practicing certified nurse-midwife at the University of Illinois Mile Square Health Centers within the Department of Obstetrics and Gynecology at the University of Illinois. Importantly, she started a nonprofit organization in 2019 called Melanated Midwives, which aims to financially support Black, Indigenous, people of color student midwives through their midwifery training programs with the goal of diversifying the midwifery workforce. Her PCORI-funded project to examine Black midwives for Black women employs evidence-based practices such as racially concordant care, Greek prenatal care, nurse navigation, and postpartum doulas as a way to address the Black maternal health crisis in Chicago and eventually worldwide. She also has work supported by HRSA in a federally qualified health center that has strengthened her development, implementation, and evaluation of the community maternal health care. This maternal health care model focuses on a community collaborative approach to address maternal health disparities. Karie's presentation today will shed light on her groundbreaking work aimed at reducing maternal mortality rates. She will present her firsthand experiences that illustrate the stark inequalities faced by Black mothers. She has built on this expertise to analyze the underlying factors contributing to this crisis and the urgent need for transformative action. We hope that this webinar will serve as a platform to discuss the future directions of Karie's innovative strategies and propose systemic changes to help reverse the maternal mortality rates. We additionally hope this webinar will enhance your understanding of the current challenges and be inspired to join the movement towards achieving equitable maternal health care for all. Karie?
Good morning, everyone. Unfortunately, I'm unable to unlock the video. Can someone release that, please? Otherwise, I'll go. Okay, thank you. All right. Good morning, everyone. Thank you so much, Dr. Stratton and NIH, for inviting me here to share my work. It is an honor to be able to present to you within the Prevention Focus webinar series and in conjunction with NIH's Pathway to Presentation program, which focuses on identifying risk and interventions to optimize postpartum health. I would be remiss if I did not acknowledge the importance of representation today. I sit before you as a single Black mother that has given birth in a hospital setting. I am a Black female researcher and PhD student, learning the importance of developing solid interventions with strategic implementation plans. I also am a Black midwife that often finds herself shielding her Black patients, her Black and brown pregnant patients from gaslighting and microaggressions and obstetric racism, all while experiencing those entities myself as a healthcare worker. And finally, I present to you as a female Black leader that has worked within some predominantly white spaces that often makes me feel as though I am not experienced nor educated enough to lead said projects, multi-million-dollar projects, or lead teams of midwives or researchers. So I say to my fellow Black and brown students, researchers, midwives, clinicians, leaders, your voice is important, your presence matters, and keep going. Your seat at the table is awaiting you. And so with that, we'll get into unveiling racial disparities and charting a path to change. I first want to start with recognizing that throughout this presentation, I will go back and forth with stating pregnant person, birthing person, Black birthing person. I will also use the word woman. I want to make sure you all understand with the use of the word woman and interchangeably, I am not intentionally excluding not including anyone who identifies as a woman. I just want you all to understand this is a learned behavior, and as I go, I will work on how to address individuals as they ask me to. So just wanted to provide that to you all today. So I'll just get right into who I am. I am Karie Stewart. I am a certified nurse-midwife. I'm currently a PhD student at the University of Illinois, Chicago campus in the Department of Human Development and Nursing Science. I am also a former director of midwifery services at the University of Chicago in the Department of Biological Sciences. In addition to that, I am the founder and CEO of Melanated Midwives, which is a non-for-profit organization that focuses on diversifying the midwifery profession. And I am also the current president of the American College of Nurse Midwives, Illinois affiliate chapter. In addition to that, I am a practicing midwife. I still, catch babies and assess moms and assess babies. And so I do that at the University of Illinois, Chicago campus. I started my career off as a public health educator, and I really wanted to do more and provide more for my community and my patients. Born and raised in the South Side of Chicago, I still reside here and I serve the same community. And so in trying to aspire to serve my community more, I wanted to pursue the path of midwifery, and I chose to become a nurse first. And so my first position, and I always say Mount Sinai, the Mount Sinai of Chicago, Illinois, trained me. And so I was a nurse there for several years. And also while I was training to be a midwife, And then I became a midwife after that. But I'm also a single Black mother who has one son who is currently in college. So unfortunately, I have to share with you some melanated faces here. And these faces represent various education levels. They represent various income levels. They represent various athletic strengths and abilities. You can also see they have various hues of Black and brown tones, various body shapes and sizes. Few faces of individuals. These are just a few faces of individuals that have experienced obstetric racism, and that has resulted in either a near-death experience or death itself, and therefore Black and brown babies without their mother. So when I speak on topics of health disparity, maternal health, I make sure that I keep in mind these individuals and the children that have had these encounters with the healthcare system. So in order to understand racial disparities, we have to clearly understand some definitions. Health disparities are what they are: preventable differences in the burden of disease, injury, violence, or opportunities to truly achieve optimal health that are experienced by socially disadvantaged populations. And so in order to really unveil these racial disparities, we need a better understanding of our health disparities. In addition to that, we also need to understand what influences these health disparities, and rightfully so. Just a few, of things that play a part in health disparities: economic stability, making sure individuals have access to income through employment, equitable employment opportunities, housing, transportation, access to parks for recreation and exercise, walkability to places in the neighborhood. In addition to that, education and language and access to those early childhood educations, as well as vocational training and higher education. We often talk about access to food, food security, food options, as well as those community engagement and social aspects within the community. Is that community safe? Is there pharmacies located in these neighborhoods? Do they have equitable access to clinics and hospitals? And if they don't, all of that transpires into having some mortality, morbidity, shortened life experience, increased healthcare expenditures, things that would not allow communities, Black and brown communities, to really achieve that optimal health that we're hoping that they should have like any other ethnicity. So in order to understand health disparities, we also need to make sure we understand health equity. And so we talked about how health disparities are those preventable differences in the burden of disease and injury and violence. But then we also know that we're trying to achieve this health equity. And this is achieved when every person has the opportunity to obtain his or her full health potential. No one is at disadvantage of achieving this potential because we have provided these resources, we have provided the access, we have made sure that the communities have top tier service and an optimal chance of getting this optimal health. So we have to make sure we understand what the statistics are telling us. This is the latest data of maternal health, maternal mortality rates based by race. And so this came out earlier this year. You can see overall the total maternal mortality rates increased from 23.8 to 32.9 deaths per 100,000 live births. It even goes further into breaking down into race. And you can see the different colors shared are over the previous years from 2018 to 2021. And so as you can see, non-Hispanic Black individuals had a really high increase from 55.3 to 69.9. And so you will also see that non-Hispanic white individuals jumped from 19.1 to 26.6. And then our Hispanic populations jumped from 18.2 to 28.0. Now we see these bars all the time. They share statistics about it. I'm a visual person. And so when I am looking to get a better grasp or sense of these national averages, I love this picture here that CDC did. And although they haven't corrected it, I corrected them for them to reflect the update of what we are experiencing now. And you can just see a stark increase from 2020 to 2021. Black mothers jumped from 55 to 70 approximately. White women jumped from 19 to 26. Hispanic women jumped from 18 to 28. And so when I'm, experiencing my patients and I'm trying to understand what the climate is, what is happening in our communities, I had to specifically take it to my community. And so the national average is that Black women are 3 to 4 times likely to die than white women. But in Chicago, in my neighborhood, it's 6 times. And so unfortunately, we have to get a better grasp of why that is happening. And so I took a personal charge to get a better understanding of why is this happening and what can we do? First, you have to, figure out what's going on. So there's a huge impact that the maternity system has on Black maternal health. And traditional maternity care is failing Black women. Black mothers consistently experience disrespectful and discriminatory health care. Black moms have alarming low rates of adequate Black mothers have alarming low rates of adequate and high quality prenatal care. In addition, there is insufficient coordination with mental health care services, specialty services, other wraparound services if needed or requested. And so you can see here, 1/3 of all the maternal deaths occur within that first year, as Dr. Stratton had told you, 52%, that's huge. And so postpartum women are often neglected once they leave the healthcare system. We have that traditional, we'll see you in 6 weeks after you've had the baby. We've implemented this 2-week check-in as if that it's a little bit better. We're going to check in a little bit earlier. And so, 2 weeks in and then 6 weeks in. Unfortunately, as Dr. Stratton showed, if those deaths that are happening or encounters that are happening within that first year, and that's 52%, doing a 2-week visit and a 6 weeks visit is just not sufficient enough. And CDC reports 84% of the maternal deaths are preventable. In Illinois, 83% of them are preventable. So we really have a lot of work that we need to do, but we really should be focusing on that postpartum period. And so this just shows some of the areas that we can address during the postpartum period, the areas that should be addressed, not just postpartum, but that may come up, that may be issues throughout the continuum of the prenatal care. And so you can see here, there's patient factors, there's education, there's that poverty level, in access to insurance, there's the community. Is there access to certain things within their community as far as healthcare services? Providing factors, knowledge, cultural competency, communication. Are we understanding our community? Do we know what their needs are? Are we communicating that? And so these are places that we need to make sure that we have in the back of our mind when we're trying to create some interventions and implement them. So what do? We need to have a serious maternity care paradigm shift. And with that, most interventions target individual level complications occurring in the hospital. Postpartum women are often neglected, again, like we said it. And so right now, no single intervention has substantially reduced maternal health disparities. The complexity of the maternal morbidity and mortality needs a multifaceted approach. And so a model of maternity care needs to center itself around what Black women need and what they're asking for. That does not exist. And so we need to have broad structural changes to truly attenuate the impacts of structural racism, and that's needed now. And as you may know, within various hospitals across the states and the nations, we are having this great push for addressing social determinant of health. Discrimination is alive and well in the healthcare system. And what Black women are sharing, that is just reinforces their distrust, and it leads to disengagement with the healthcare system. In addition to that, we want to make sure that we continue to see the loss of Black lives during pregnancy, while giving birth, or during the first year postpartum. And that those entities, those incidences are causing much more divide and distrust and disengagement with the healthcare system. So what do? How do we regain the trust of Black birthing people in the clinicians, in the physicians, in the midwives, in the healthcare system overall? How do we get Black birthing people more engaged in their prenatal and postpartum care? And it's not just by addressing their social determinants of health. We give them what they're asking for. We listen to Black birthing families and people. We give them what they're asking for. Providers that look like them. Supportive and patient-centered prenatal care. We assist in navigating the complicated healthcare system, and we support and provide resources, not only during pregnancy, while they're laboring, but also after they give birth. I cannot go on and talk about racial concordant care if we can't talk about how racial concordant care originally started. We have to recognize how gynecology and obstetrics was founded on racism. We cannot negate that. We cannot push it under the rug. We have to acknowledge that and really be conscious about bringing that to the forefront when we're teaching our clinicians who are providing care for Black and brown patients. So with that, and I speak to this as a midwife, granny midwives in the South took care of their family members who were also with them as slaves. There were also these same midwives that took care of their slave owners and their slave owners' wives. And so this was a very valuable individual, a profession in the South back in the day. And so unfortunately, there was this ideal that these granny midwives who have been doing this and very successful and not having any concerns and issues, that they were dirty, that they were causing deaths of moms and babies. And so in comes the Shepherd-Towner Act of 1921, bringing in this licensure and this regulation, which shifts the birth care to the state. Of course, this transition of the birth care is regulated to clinical practice, and it excludes these Black midwives. And so when you put an exacerbating amount of cost on certain things or requirements on certain things, that increases the gaps on who can be involved in certain things. Unfortunately, that still is happening today. Early in 1900s, 50% of all the births in the US were attended by midwives. Today, 90% of them are by physician care. And we have various midwives. We have certified professional midwives. We have certified nurse midwives. We have certified midwives, lay midwives, and they're all in the communities doing this work, okay? But right now, approximately 70% of certified nurse midwives, and I'm just speaking to nurse midwives, are Black. That's not enough. We need more. So, why do outcomes improve when providers and patients share the same race? It's the enhanced trust, in someone that looks like them, that may have gone down this journey, that they can relate with, that they can openly talk to about their experiences, and not feel judged about those questions or concerns that they may be having. They become more engaged with their care. It's a true shared decision-making experience, and there's much more communication. Patients and families are willing to ask things that they would not have normally asked, and those questions or concerns that they bring up could be vital to how we provide care. And it's important that we have that solid communication between our patients. So what did we do? We created melanated group midwifery care. Melanated group midwifery care is a PCORI funded grant, $10 million, started off at 10 million, got down a little bit, but still $7 million grant that focuses on four vital components. And we know that it is hard to navigate the system. We know that individuals are asking for racial concordant care. We know the evidence behind group prenatal care and its outcomes for pregnant patients. And we also know how vital postpartum doula support can be during that postpartum period. We have doulas in the community already doing this work. And so this is not something that we should not be reinventing. We should be opening our doors and making sure that we're embracing our communities and the community organizations and putting them at the table with us to really address our concerns with Black maternal health. And so that's what we have done. So just to go a little bit more in depth on those components, and MGMC stands for Melanated Group Midwifery Care, just so you are aware. But this bundle includes 4 evidence-based strategies. With that being said, the first one is racial concordance care, and that's between the provider and the patient. And so within our cohorts, we have a Black midwife that is leading a group of Black moms. And this researched evidence-based approach increases healthcare engagement. It earns this patient's trust. It increases their satisfaction in the healthcare system and in their provider. And it halves the racial disparity in neonatal mortality. And so this racial concordance and continuity, we have actually strategically made it throughout the other individuals who are on this team. So our nurse navigator is Black, our midwife is Black, and our doulas are Black. And so all of our individuals within this component identify as Black. And that was important to us. The next component would be group healthcare. And some may know it as centering and some may know it as group prenatal care. But we identified as this group prenatal care here with MGMC because we have been very strategic about creating the components, the curriculum, as well as the topics that we discuss in group prenatal care are catered to Black women, Black moms, Black communities, things that they experience that can be barriers, that can be issues that they experience that other individuals may not experience. And so we really made sure that we tailored this group prenatal care to them specifically. So it is structured to disrupt those higher power hierarchies. The midwife is sitting in a circle with their patients. No one is standing, hovering over them. We are all in a group interacting consistently. We're building a support system and a community that these moms are having. And so this is associated with better attendance, mental health, well-being, satisfaction, lower rates of preterm birth, and higher rates of breastfeeding. Stronger results for these is what we need for our Black and Brown moms. And so this is an important component that we felt was necessary to make sure that we're empowering moms as they go on into not only just their pregnancy, but into their postpartum care. The third component, which is very important, is our nurse navigator. There has been much research on how navigating the healthcare system can be very difficult. And at this point, it's very difficult no matter what ethnicity you are. The healthcare system can just be very tricky. And so we want to make sure that our Black and Brown patients do not get lost in that. And so our nurse navigator is well educated and versed in how to navigate the system and assist patients with that. It's extensive. It deals with active referral linkages and following up with prenatal care. If we have to have antenatal testing, making sure that that's arranged, making sure that individuals know where they need to go. It's proactive versus reactive management of those obstetric complications. And it's truly shared decision-making. We can't just make random appointments for anyone and say, hey, yeah, show up to this appointment. No, we need to understand their schedule, their lifestyle, what they have going on, and then we accustom their care to them, and that's centered care. Finally, we have the component that I think is the most important and a little bit than the others, but very vital. And I would say it's because the postpartum doulas provide in-home support. And as we said earlier, 50% of those instances happen in that postpartum period. And so what we decided as a team, we really want to decrease postpartum depression. We really want to show that Black and Brown individuals want to breastfeed, want to continue to breastfeed. So we want to increase those numbers. We want to improve bonding between mother and baby. And we want to make sure that they improve their maternal sense of control of those complications. And so we're empowering them. But we're utilizing someone that in the community that they're trusting. And so the community doula is a resource linkage. They provide that postpartum support. And so if something happens in the postpartum period, they are the individual that will guide them back into the healthcare system and get with our nurse navigator or our midwives to get them the care that they need. So this is our community partner. I'd be remiss if I did not share who they were and how tremendous they are in the work they were already doing, and then honored that they joined us. Chicago Birthworks Collective has been doing this. It's a daughter and mom run community-based organization in Chicago, well respected. And so they are really boots on the ground in addressing Black maternal health, but also providing resources that all moms should have, whether it be prenatal yoga or chiropractor, or just a support system for dads. It's really a great community organization that we felt was vital to ask to come join us, just because of their experience, but also to lead us in this charge of really getting moms to come back into the system if they needed to, or feel supported during postpartum. Some other organizations, just so you know how we also have a community advisory board. It was very important to us to share with the community, but also more importantly, get some input from the community about their experiences in birth, their experiences in postpartum, and what do we need to consider when we're creating an intervention and implementing this intervention, because again, it's not just creating and handing out. We need to consider some things for the community that we're providing this intervention for. So MGMC, again, as I stated, is PCORI funded grant. Our study population consists of self-identified Black or African-American birthing women people, 16 years or older, who have a single-term pregnancy, less than 24 weeks pregnant, English speaking. And so if anyone who needs sole management by MFM, which is our maternal fetal medicine, or our high-risk obstetricians, they are ineligible. But if they are cleared by the MFM or the high-risk doctor, there could be some co-management. And then if the patient consents, after they hear about the study, we provide them with information and what we're looking for, what we're providing them with. There is compensation. And so then they are randomized. And our hope is that once they're randomized in, we will get half of the number that we're looking for, 216, will remain in the usual traditional care one-on-one with a provider. That provider can be a midwife, that provider can be a physician, that provider can be a women's health nurse practitioner at our institution, it can be a PA at some other institutions, but in our intervention group, they will be placed in a cohort with other mothers that have similar due dates and similar gestational ages, and have a Black midwife and a nurse navigator and a doula assigned to them as well. So this is a random controlled trial design. And as you can see here, we're just comparing our intervention, which provides the group prenatal care and the care coordination with the community doula, to that usual care. Our primary outcome is patient engagement and trust. Our secondary outcome is the implementation evaluation. So our observations, our study notes, our individual and focus group interviews, and that's focus intergroup interview, individual and focus group interviews with the midwives, as well as the moms, because we want to get information from all the individuals involved. It's vital. So we hypothesized that MGMC intervention participants will have 20% higher engagement in their prenatal and postnatal care compared to those in usual care. And so how we're measuring this, or where we're gathering this information from, is through our electronic medical record system. And so these are the things that we're going to gather from this. And so we are providing that information from our records within the hospital. We also hypothesized that women in MGMC will report better outcomes for 6 patient-reported outcomes. So we're looking at patient activation, autonomy, and so we're looking at provider trust, satisfaction, as well as their mental well-being and respectful care. And so these are self-reported surveys that they will get throughout their care with us. So MGMC also aims to increase linkages and address the social determinants of health, leading to increased risk of morbidities and mortality. MGMC women will have more appropriate care, we feel. And so these medical complexities, the referral and treatment pathway will examine these experiences, examine how they receive the referral for their antenatal testing, examine how long it took them to get back into the system. And so we will gather that from not only from qualitative interviews and information that they provide us, but we'll also check into our electronic medical record review system as well. So just a visual of our patient engagement and trust. We have our racial concordance and continuity. We have our midwife, we have our care coordinator. So we were strategic about that. You can add the doula, and you can also add our moms in there. And so that's that racial concordant care. We have that group prenatal care. We're trying to disrupt those power hierarchies. We're trying to have more engagement and interactive learning. And we're building a support system for our community, families, and moms. In that care coordination, we're making sure we're addressing those unmet needs. We're providing appropriate referrals in a timely manner. We're getting them attached to some social service linkages without waiting long periods of time. But then we have done things inside the hospital system. We're also addressing what needs to be addressed on outside. And that's making sure we have the community doula, who also has experience with resource linkages, and will continue to provide that postpartum support over 12 months. An entire year, the postpartum doula will be providing support to our cohort moms. So our long-term goal is to truly attenuate some impacts of structural racism and decrease maternal morbidity and mortality. Okay, you can see as a figure on the right, just a timeline of how those surveys are going to be provided to the moms. So we do a baseline survey, we do another at 26 to 28 weeks, we provide another at 35 to 37. They give birth, we also have surveys in the postpartum period as well. And so in addition to getting this evaluation In the beginning, we also are making sure this is implementation evaluation as well. We are assessing things as space to have our group prenatal care, scheduling for our midwives, scheduling for our patients, making sure that the healthcare system knows that this prenatal care that we're providing looks different, but it is the same. This is prenatal care. We are providing care. This is not a project. This is not some experiment. This is prenatal care, and is just as effective, if not more, than traditional one-on-one for this population that we're serving. So what do we need to do? We really need to focus on that race is not a biological reality. Racism is the problem. We have to actively address not only our personal racism and implicit biases, but we also need to do it collectively as a system, and not just as seminars here and there, modules here and there. What are we actively doing to address the racism in our healthcare institutions? Yes, it's a touchy subject. Yes, we get a little anxious when we talk about it. We don't want to assume that I am this way, that I don't like people, I have a certain bias. This is our reality. And so once we sit with that and address that, then we can move forward and save lives. And I specifically touch on some of the things that we need to do locally within our states, but federally as well. And so I just share what has happened in Illinois, just because I reside here. But Illinois is the first state to extend their continuous eligibility for full Medicaid benefits through 12 months. Every state should be doing this, okay? If we really truly want to have an impact on postpartum, we should be having insurance coverage 12 months at minimum after delivery. Illinois has also passed legislation to cover in-home postpartum visit under Medicaid. And if we know that 52% of those things are happening in postpartum, and we have the ability to provide some in-home postpartum visitation, we should be making sure that that is happening. Implementing various policies, we should be focusing on our implementation strategy while addressing the policy work, okay? Yes, we're pushing the policy, but how do we plan to implement this and truly get it going? Building those pipelines for melanated midwives, for our melanated physicians and nurses and support staff, our doulas, our community health workers. How are we making sure they're getting paid an appropriate living wage? How do we know that they feel supported and a part of the community when we're trying to have conversations at the table about addressing the community? If we're not having the organizations at the table to talk about how we're going to help them, then we're just making decisions for them, and we no longer need to be doing that. We want to build community partnerships with our community organizations, and we want to support legislative bills such as Momnibus. And so we really want to make sure we're looking at those things that will support the organizations and the community that we serve. So what I did, and I will ask you all to do, is I took a personal charge. I really wanted to focus on what I could personally do in my institution, but also within my community. And I've done that. As a PhD student, I am centering the voices of Black birthing people, as well as the Black midwives. The voices of Black midwives need to be heard. And so there's a different story that needs to be told. And so we will definitely share that as well. As a director, the newly director of the University of Illinois Miles Square Health Institute, Women's Health Institute of Excellence, it is my focus to make sure that we are providing reproductive and maternal health care accessibility to Black and Brown communities, specifically on the South Side of Chicago, who has experienced a tremendous amount of loss in healthcare access when it comes to maternal spaces as labor and delivery units or clinics. And so I really wanted to make sure that our community saw us and reached out to us and recognized that we are there and willing to provide them care and support that they need. As a founder and a CEO of Melanated Midwives, there's not enough Black and brown midwives. And so I took that to heart as a student when I didn't see enough faces that looked like me. There was not enough mentors that I could reach out to that could support me through my journey. And so I want to make sure that we have enough of that for those who are coming from behind. As the president of the American College of Nurse-Midwives Illinois chapter, I attempt to try to lead the charge midwifery in Illinois, making sure we try to have the connection with our communities, making sure we support each other in our work, not only in our various institutions, but in the community as a whole. And that can be difficult, in a large state, especially when services in rural areas can sometimes be different, but very much similar to an urban area. And so we have to consider the landscape and make sure that everyone can be equipped and fully covered. And then as a certified nurse midwife, I will continue to serve and advocate for Black and brown moms and birthing people and their families. It warms my heart when people come to specifically look for me. And so, and now that I have a team, it is wonderful to say that we are providing a very impactful care. And we're hoping that as we at the University of Illinois and the Melanated Midwives are an example of how this can be upscaled to other institutions. This absolutely can be done. And as a single Black mother, I will just continue to share my story. And so it's important that you see everything that is happening around us, but we're taking a pause to really, truly, thoughtfully think about how we can be impactful and how we can truly have interventions that are making a change, that are doing what we hope to do for the sake of our patients and our community and what they're asking for. It's, we can't create things and say, oh yeah, this will work, and we don't have them the individuals who are affected at the table. And so we have purposely done that with Melanated Group Midwifery Care. And we have had our challenges, do not get me wrong. This has not been smooth sailing, but with anything, we go through a journey, we have some ups and downs, and we figure it out. We have gotten to the point that we have had to have our own social worker for Melanated Group Midwifery Care because we needed to make sure that our patients' social determinants of health were addressed. And not that they wouldn't have been addressed with the entities of the hospital, but we just knew how large of a group that we would have, and we needed some support, some more support. And so we are working with our social work team at UIH and making sure that these initiatives that we are putting in place to address social determinants of health, that we're just not collecting this information. We're actually collecting it and doing something about it. We're addressing it. And that's what we should be doing. So with that, I want to thank you all so much for sharing, for coming along, for listening to our journey and what we have attempted to place before you as a goal to really address the Black maternal health crisis. Thank you for coming.
Thank you so much, Dr. Karie, for a wonderful presentation. That was really great and very insightful. Thank you so much again for that. And so I just wanted to remind participants that the webinar was being recorded and an archived recording and the slide deck as well will be shared and posted to ODP's Prevention in Focus website later on in the upcoming weeks. We are almost at time, but there were a lot of questions as well in the chat. So thank you all for your questions. We will figure out a way to see if we can try and get some of those questions answered. But I think we have the ability to ask a question or two. And so one question I have for you from like the audience is, how can allies help and provide support to Black birthing people, Black midwives, if they are not in the medical field or in research?
I'm sorry, say it one more time.
Okay. The question is, how can allies help and provide support to Black birthing people, Black midwives, and so on, if they are not in the medical field or in research?
So Black midwives who are not in the medical field, and I assume not in the hospital institution itself, are midwives who are doing home birth or who are doing birth center work. They need to donate. They need to go to these organizations and make sure that they're supported with the resources they need to get to their patients. Making sure that if they have some connection to the hospital, how can we make sure we have some collaborative connection? Some moms who give birth in a home or in a birth center may eventually need to go to the hospital for whatever reason. Do we have that collaboration? Do we have that connection? Do you know who I am? Do you know what I'm doing? And how can we support each other? And that's why I really emphasize making sure you understand, as institutions, we need to understand our community. We need to know who we're truly serving and not just saying, we're doing an analysis of a community and then we just kind of know what's happening. No, are we sitting down at the table with the community members? Are we sitting down with moms and dads and the family and saying, hey, what is your experience living here? What has happened? Lots of things have happened since the pandemic. And so we need to really gauge what's going on. But we also want to make sure that those individuals who are in the community, the midwives, the other organizations are supported and know we support them and are here to help. And there's various ways that we can do that, whether it be financial or physically being present with them. We need to do so.
Okay, awesome. Thank you so much. And I think just one last follow-up question that we have. So I guess on the policy and legislation level, what kind of policies and legislation can help support melanated birth workers?
We need to pass Omnibus.
Okay.
Passed. I mean, I don't have to say anything else about that one. It's 12 bills that's going to help a tremendous amount of individuals. And so whether that be families, whether that be community birth workers, that means our state individuals, our health departments, all of that, we need to make sure that we have to pass Omnibus. It is urgent. It is imperative.
Awesome. Thank you. And thank you so much again, Dr. Stewart and Dr. Stratton, for elevating this very important topic of Black maternal mortality and pathways to start to address it. And I also wanted to say thank you so much as well to my ODP colleagues as well. And thank you as well to all the participants and all the people sharing in the chat, the audience. It was a very wonderful conversation as well as resources being shared. So thank you all. And so if you have, again, the recording of this webinar will be archived and shared at a later time. If you have any questions about the webinar series or today's presentation, please contact us at email preventioninfocus@nih.gov. And thank you all again so much for attending this webinar. And with that, we will end.